Good afternoon, everyone. This is Rochelle. Thank you so much for joining us this afternoon. I'm honored to have two great presenters here on our call today to share with us their research on Kentucky Medicaid. I work here at the Foundation for Healthy Kentucky as the Community Health Research Officer, and I work on the Foundation's data initiatives. That work includes the Kentucky Health Facts data website, the Kentucky Health Issues Poll, an annual health issues poll we work on in conjunction with the Health Foundation Interact for Health. And I'm honored to work on and coordinate this training series that you're on today that we call Health for a Change. Health for a Change, the Foundation began in 2011, and this training series has reached Kentuckians in all 120 Kentucky counties. And we provide training and capacity building workshops and webinars just like this one. The Foundation for Healthy Kentucky was founded in 2001 with investments of $55 million, and we work on the health of Kentuckians. We're a nonprofit, nonpartisan organization funded by an endowment. Our mission is to address the unmet health needs of Kentuckians. The Foundation does that by a number of ways. One, developing and influencing policy, improving access to care, reducing health risks and disparities, and promoting health equity. And again, our conversation today and discussion with these two researchers on Medicaid and its impact on access to care is very timely and top of mind. I'm thrilled all of you are joining us today. The Health for Change training series, including this webinar, are recorded and archived on the Foundation's website, healthy-ky.org. There you'll also find a schedule of upcoming events. We have some great lineups for the remainder of the calendar year. September 27th, we'll hold a workshop in Northern Kentucky at the Health Department, and that will focus on local smoke-free campaigns. That workshop is sponsored in partnership with Interact for Health. On October 4th, we'll have another webinar about measuring advocacy efforts, so that'll be the topic of evaluation. October 24th, we'll be hosting a Working with the Media workshop at the public libraries in Paducah, Kentucky. And on October 25th, we'll have another in-person workshop. That'll be the second part on our advocacy efforts and evaluation, also held in Northern Kentucky. So please feel free to join us for those events. Share those with your friends and colleagues. My final announcement for this morning before I turn it over to our speakers today: the Foundation for Healthy Kentucky sponsors annually the Howard L. Bose Memorial Health Policy Forum. This year it'll be in Lexington, Kentucky on Monday, September 24th. The topic is Kentucky's substance use epidemic. That event is on a waiting list. As we know, people's schedules change, so if you're interested in attending, please add your name to the waiting list and a spot may come open for that Memorial Bose Health Policy Forum. Finally, I just wanted to remind everyone on the call that I tweet out of Kentucky Health Facts, and the Foundation for a Healthy Kentucky tweets out of Healthy KY. You can see our websites there, healthy-ky.org, and the data website, kentuckyhealthfacts.org. As I mentioned, this webinar is being recorded, and the recording of the webinar and the full slide decks from today's presentation will be posted to the Foundation's website later this afternoon. Everyone that's logged into the computer, we welcome your questions via the chat function, so please feel free during the call to chat in your questions and comments to our presenters this morning. It is afternoon here in Kentucky. I know I said this morning, but I'm thrilled to turn it over to researcher at Harvard T.H. Chan School of Public Health, Ben Summers. Thank you so much for being on the call. Welcome, Ben.
Thanks so much for having me. It's really an important topic and definitely very timely, so I'm happy to be a part of the webinar, and thanks to the Foundation for hosting it. So I'll jump right in. I guess let me tell you a little bit about myself. I'm a health economist at the Harvard School of Public Health, and I'm also a practicing primary care physician. And my area of research interest is really about access to care, affordability of care, particularly for low-income populations, and health insurance. And so Medicaid expansion has been an important area of research, as well as the broader Affordable Care Act over the past several years. And what I'm going to do today is present some of the results from a 4-year study that we recently completed in Kentucky, along with several other states, assessing the effects of the Affordable Care Act on low-income adults. And I'll come back at the end, and this may come up during the Q&A, but we're building on some of our prior work now and looking to evaluate the changes that are underway, or at least proposed for Kentucky in the waiver program in Medicaid, and I'll be happy to talk more about that as if people are interested in discussing further. But what I'm really going to focus on today is where Kentucky has been and what has been accomplished, and what has the effect of Medicaid expansion been through the first several years of that expansion in Kentucky. So let me turn to the slides and make sure I can operate them the way I'm supposed to. Hold on one second. And there we go. Okay, so I want to acknowledge this is work that was funded over several years with generous funding from the Commonwealth Fund, as well as some additional support from the Agency for Healthcare Research and Quality that supported some of my effort on this. Catherine Clark did a lot of the grunt work and legwork as a research assistant on this project, and then my co-authors you'll see at the end, who also obviously played a critical role in this work. So to introduce the motivation here for this project, when we started this in 2012, 2013, obviously we had little idea of what the health policy landscape would look like 5 years later. I think there was a great deal of uncertainty as to how Medicaid expansion would play out, what would happen in subsequent elections. But despite not knowing where things would head, it's still very much the case that here in 2018, the work we started 5 years ago remains even more relevant perhaps than ever before. The fate of Kentucky's Medicaid program is quite unclear. I think most, if not all of you, are quite aware of the legal battle going on over the waiver program, the Kentucky Health Program. Governor Bevin has threatened to potentially roll back the Medicaid expansion if the waiver isn't ultimately implemented. And more broadly, we saw this particularly at the national level last year during the heated congressional debate over repealing and replacing the Affordable Care Act, but continues to be a part of the conversation in Kentucky and elsewhere as policymakers look at the future of Medicaid, which is, what is the value of having health insurance? And is health insurance actually necessary for accessing health care? And is Medicaid coverage good enough to really improve or benefit the lives of people who enroll in it? And so, here is just an image that I think, from that debate last year in the middle of the congressional discussion over repealing the Affordable Care Act, that the Speaker of the House, Paul Ryan, made the case that health care access is not the same as coverage. And so changes to the Affordable Care Act that might lead to fewer people with insurance isn't necessarily the problem that many opponents felt that it would be. That was the argument being made. Our research has a lot to say about what it really means for people to gain health insurance coverage. So let me jump into the specific goals of this project, and then I'll tell you how we did it and some of the key results. Our overall objective was to assess changes in healthcare use, so how people were interacting with the healthcare system, not just whether they had an insurance card, but were they visiting the doctor, were they getting prescriptions filled, and what did they perceive as the overall effect on their health after 3 full years of the Medicaid expansion. And we're focusing here on low-income adults, those adults whose incomes make them potentially eligible for Medicaid if the state expanded coverage, and in the age range from 19 to 64, people who are too old to qualify for coverage as children but too young to get Medicare. We were interested then not only in looking at the overall effects on low-income adults, but in particular for some of the highest risk people in this population. Those are individuals who have chronic conditions, and I'll tell you a little more about what kinds of conditions we were studying. And then thirdly, we're interested in not just Medicaid expansion, but in different forms of Medicaid. And this is relevant for many states that are considering alternatives and other waiver programs. So here we're going to be looking at Kentucky, which implemented a traditional Medicaid expansion, didn't have a waiver in 2014. The state simply expanded coverage using the state's existing largely managed care-based program. And we compare that to what happened in Arkansas, where they received approval from the federal government to take those ACA dollars, the Affordable Care Act Medicaid expansion funding, and put most of their low-income population into private coverage. They subsidized plans through the marketplace, and that's how those individuals gain insurance. And we're going to compare those 2 states to what was happening in another state in the South that did not expand coverage at all to the low-income adults, and that was in Texas. The design, we surveyed over the 4-year period about 11,000 low-income adults spread evenly across those 3 states, Kentucky with the Medicaid expansion, Arkansas with the private coverage model, and Texas where there was no expansion to low-income adults. Each year we surveyed a different group of people, so we're not following the same individuals, but what we get is a slice of the population in these 3 states each year, and we did it towards the end of each calendar year. So we have a pre-ACA observation or pre-ACA data point in 2013, and then we came back in the last 2 months of 2014, 2015, and 2016 to track how these outcomes evolved over time. And we were really looking primarily at this question of what does it mean to expand coverage. So we looked at Arkansas and Kentucky compared to Texas before and after this big change in insurance availability. And then we also wanted to kind of make this into terms that was a little more interpretable, because not everyone in our survey gains Medicaid. A lot of the people already had coverage. Some of the people remained uninsured. I'll show you numbers on that shortly. So one of the questions that policymakers often want to know is, well, for the individual who went from uninsured to Medicaid, what did this mean for them? And so we'll put the numbers in that framework so that it kind of makes interpretable. You'll understand what the real world impact is on a person's life. So the design of the survey, we did this by telephone. We used a well-established survey company that was able to do a random digit survey of people meeting the following criteria. We limited the sample to U.S. citizens to make sure that they would be eligible for Medicaid. I already told you about the age range, 19 to 64. And they had a family income below the cutoff for eligibility under the Medicaid expansion, 138% of the federal poverty level. The sample, we talked to people both on landlines and cell phones to try to capture as broad a representation as possible. And for the same reason, depending on the language the person spoke, we were able to do the survey in English or Spanish. We use survey weighting, which is a standard method in these kind of telephone polls, to produce numbers that are representative of the state's population. About 1 in 5 people we called completed the survey, and I'll talk a little bit about how that affects our results. But overall, we've gone back after the data were all collected, and we've compared our results to some of the top-notch federal government surveys that the Census Bureau does. And our results track pretty well, and so that gives us confidence that these are high-quality results that are really capturing important trends in Kentucky and these other states. So the first figure here captures the top-line result, the big finding that you would expect, which is when you expand Medicaid, a lot more people gain coverage. So these lines trace out the share of low-income adults who don't have any health insurance. So what share are uninsured? If you go back to 2013, before the Medicaid expansion began, what you see is that all 3 of these states, Texas, Arkansas, and Kentucky, had pretty high numbers of people without coverage in this low-income population, about 40%. So 2 in 5 low-income adults in these states had no insurance when we started our survey. By 2014, that number has dropped pretty dramatically in Arkansas and Kentucky. So you see those 2 lines drop down to 20, and in Kentucky down to around 12%. And then the lines continue to track down over 2015 and 2016. So there's additional people signing up for coverage each year, and that uninsured rate drops down even further by 2016. Meanwhile, in Texas, there's a little bit of a drop. So some people in this income range in Texas did gain coverage, but much less than what we saw in the 2 expansion states. And it flattened out really after 2014. So there's a big gain in coverage going on for large numbers of people in Arkansas and Kentucky. And that's not a surprise, but it's still important to see. The real question is, well, what did that coverage mean for people? So now I'm going to show you, this table has a lot of different numbers on them, and I'm going to walk you through what I think are some of the most important ones, both in terms of policy relevance and also as a practicing primary care doctor, what are the things that I worry most about for my patients in terms of their ability to access care. So the first is these 2 measures at the top left in the red circle. Do you have a personal doctor? So a very simple question, right? If someone doesn't even have a clinician that they see as their primary care, their personal doctor, it's hard to say that they have good access to health care, right? This is the front door for most people. Where do they start out and what do they get? And we also ask them if they have a usual source of care. And what these numbers tell you is that for someone who went from uninsured to gaining coverage through the Medicaid expansion, there's a 60-point increase in the likelihood they had a personal doctor and a 40-point increase in the chance of that they had a usual source of care. So these are big, big numbers. And that means that a lot of the people who previously were uninsured didn't have primary care and got it afterwards. And the stars here, the little asterisks, show you that these are all statistically significant. These are big changes that are well beyond the margin of error in our survey. We didn't see much change in difficulty getting primary care specialty appointments, but we do see, in addition to more people having a primary care doctor, we see fewer people that say the emergency department is the main place they like to go for their care, and that number is that 23, that negative 23. And related to that point, so fewer people say the emergency department is their usual location of care. We see fewer people going to the emergency department at all. So we see that 27% less, or 27% fewer people with an office visit, with an emergency department visit in the past year, whereas we see an increase in the number of people who are getting office visits. So this is encouraging. This is what we'd like to see happen when people gain coverage. They're better able to get primary care. They're better able to be seen in the office. And they're less likely to need to go to the emergency department, especially for kind of routine care. There are some emergencies that are no matter whether you have coverage or not, can't be treated in an office. And if someone's having a heart attack, we want them in the emergency department. We don't want them waiting for an appointment. But what we see here is that there's less reliance on the emergency department for kind of routine care. That's the usual place you go get your medical care. And now I should note that that's not necessarily the same as every study that's been done on Medicaid, and I'll come back to that in a little bit. Some studies have found that giving people Medicaid leads to more emergency department use. So our studies suggest that it may depend on the circumstance, but at least in our data, we see this promising reduction. And then when you think about how people pay for their care, it's not surprising, but when someone gains Medicaid instead of being uninsured, they have a much easier time affording medical care. So here you see that there's a 59 percentage point drop in people telling us, I had trouble paying medical bills after they gained Medicaid. So that's a big deal. You think of not only whether people can go in and get the care they need, but after they leave, how much distress is this going to cause? Are they going to have to take out additional loans? Are they going to have trouble paying their other bills? And in some extreme cases, though we don't measure it here, are people potentially going to have to think about bankruptcy? So here we see a big drop in people having difficulty paying their medical bills after they gain Medicaid. And then we also see a pretty sizable drop in how much people are having to spend out of pocket. And this is because, when you don't have coverage and you go to the emergency department or you go to a doctor's visit, you're going to get a big bill. And here we see that with Medicaid coverage, people are not spending nearly so much out of pocket. And that makes sense and is consistent with this idea that the insurance is improving their ability to get care. And then in terms of the types of care they're getting, this is another important question. So I think we've already seen from the first set of numbers, this is not an empty insurance card. It actually gets people into the door. They're seeing and getting care. But are they getting the kinds of care that we think will improve their health? Well, we see that there is some evidence of that too. We ask people whether or not they've had a checkup in the past year. We see a big increase, 64% more with a checkup in the prior year. We ask people if they get a cholesterol check and a glucose check. Well, both of those numbers went up, but only the glucose check was significant beyond the margin of error. But we see more people are getting their sugar checked, and that's a good thing. And then below that, we see when you ask people, well, are you in good health? And so we give people a question that's been tested in a lot of other studies, and we say, is your health excellent, very good, good, fair, or poor? And it turns out that after Medicaid expansion, people said that they were more likely to be in excellent health. Now, is that a real measure? Is that just how they felt, or was that objective? Well, it turns out that when other people have looked at this question in other studies, that this self-reported health measure is a very strong predictor of survival, and that people who say they're in poor health die at 5 to 20 times higher rates each year than those who said they're in excellent health. So this is an important measure, and we see some benefits of gaining coverage. Now, what about chronic conditions? The formatting mostly came through here. The footnotes are a little hard to read. But what we saw in this sample of low-income adults is that a lot of them actually have chronic medical problems. So here you see 50% of our sample said they had high blood pressure. 12 to 16%, depending on the state, had coronary artery disease. And you can read down the chart. A lot with high numbers with asthma, with diabetes. Depression was actually the most common condition. And overall, across everyone in our sample, on average, people reported at least 2 of these conditions in the list above. So this is a population that's got a lot of healthcare needs. This is not a healthy group that never needs to see the doctor. And when we limit our analysis just to this group, so basically the same results I showed you earlier, but now we're going to zero in on the people who said, yes, I have a chronic condition. We see a very similar set of results more people with primary care with a personal doctor, fewer people delaying care because they can't afford it, fewer people skipping medications due to cost. Well, that's a really important one for chronic conditions. If you think about high blood pressure and you think about heart disease, you think about asthma, these are conditions we manage mostly through the use of medications. And if a patient can't take a medication or they skip a couple of weeks because they can't afford it, that has a real risk to their health. And we see that after people gain Medicaid, they were much less likely to do that. They were able to take their medications regularly. And on down the list, you see improvements. And then this right near the bottom where it says regular care for chronic condition, a lot of the people who had these conditions said they never really saw a doctor about it or weren't getting care consistently even though they knew they had medical problems. And we see there's a 56% increase in how often people are getting regular care for these major medical conditions. So all of this is suggesting that coverage is very meaningful in this population, that people are getting better access and better care. Now you may be wondering, I mentioned early on that there's these two different models of coverage we're comparing, the Medicaid expansion in Kentucky versus the Arkansas private coverage option. Turns out that when across all those different outcomes that I mentioned earlier, basically the results are pretty similar for Arkansas and Kentucky. In both states, low-income adults really benefited compared to Texas where coverage wasn't expanded. And other than the fact that people in Kentucky ended up mostly with Medicaid and people in Arkansas mostly ended up with marketplace private coverage, the rest of the health outcomes we studied look very similar. So our conclusion from this was the most important thing is, do you have any insurance? Whether it's public or whether it's private doesn't seem to matter as much. And I think that's really important to keep in mind because we do sometimes hear the political argument that Medicaid coverage is worthless if only we could get people into private insurance. And what we found is, well, actually both are pretty good and both make a big difference for people compared to having no insurance. So taking stock of the big picture here and how does this fit into the current policy debate before I turn things over to Lynn. So first off, it's really important to recognize that Medicaid expansion in Kentucky led to big changes, not only more people covered, but improvements in a bunch of measures that really do matter when we think about a patient's health and their health care. We see people better able to afford their care. We see better access to primary care. We see people better able to afford and stay on their prescription drugs, especially among those with chronic conditions. And then overall, we see that people had reported their health status as being improved afterwards. And then we see in the subset of the people in our poll who had a chronic medical problem, we see similar benefits, that they're getting more regular outpatient care, better able to stay on their medications, and they describe their health as having improved after gaining coverage. Some other important points in this one, unfortunately the formatting is a bit messy here. The coverage expansion was not a one-time immediate effect. We saw in those initial graphs that more people signed up in year 2 and then more people signed up in year 3. And so this tells you that it does take a little time for people to find out what they're eligible for and enroll. And I think this has an important implication as we think about changes to the Medicaid program, which is that people's lives are complicated. I'm a doctor and I'm a health policy researcher, so I think about healthcare all the time, but most people don't. Most people think about healthcare when they need it. And in between that, it's not higher on their radar screen. And what that means is that they may not have signed up for something they're eligible for. They may not know the details of the program. And with any kind of complex waiver program like Kentucky Health, there's always the risk that a lot of people aren't going to understand the details and might get confused or might even just be turned off from trying to enroll if they don't understand how it works. But we certainly need to follow these changes in policy not just once but over a longer period. We also found these benefits of improved self-reported health in our studies. And I should point out that not every study of Medicaid expansion has found that. Some of our prior work before the Affordable Care Act looked at several states that expanded Medicaid and did find not only improved health but improved survival. But some of the other more recent studies on the Medicaid expansion have either found small benefits to health or not significant effects. It seems like it depends somewhat on how long you follow people for, and it also depends on how many people have gained coverage. If you look in a state where only a small number gain Medicaid, it's hard to find out whether there's a health effect. Kentucky and Arkansas had 2 of the largest gains in insurance coverage of any state in the country, and that means that our study is really well situated to try to find those effects because we do see so many people gaining coverage that then we can measure other downstream effects. We do still see that there are some barriers to certain types of care. A fair number of people in our survey are reporting that they do struggle with affording or do struggle making specialty visits. So I'll toggle back real quick to that finding. If you look at this graph, so we see about there's 14% trouble attaining a specialist appointment. Now that's not significant in our study, but it at least raises the possibility that some people are wanting to get care that they haven't been able to. And there are other studies that have found similarly. Medicaid does a pretty good job of getting people into primary care, but in some cases, some states, some parts of the country, there may be fewer specialists. And then finally, coverage is not only leading to more affordability, but it seems to be producing more efficient care where people are getting more prevention, they're getting more outpatient care, more chronic disease management, and a little bit less in the emergency department, though, again, some other studies have found mixed results on that question. So what are the implications of these findings for kind of the ongoing policy questions facing Kentucky and more broadly many other states that are thinking about changes in Medicaid? Well, the first thing to know is that the first 3 years of Medicaid expansion in Kentucky was very beneficial. It made a big difference in coverage, and in particular for low-income adults and those with pre-existing or chronic conditions. Any change to the policies in the Affordable Care Act or Medicaid related to pre-existing conditions or management of chronic conditions could then be, could put at risk some of those gains. And more specifically, the waiver proposal, the Kentucky Health Program, adds required premiums for people to enroll in Medicaid, more cost sharing, so more out-of-pocket payment, and then probably most notable, the requirement that people have either are working or other forms of community engagement that then make them eligible for Medicaid. And if someone doesn't document, doesn't show that they are working or meeting one of those other categories, they would be locked out of coverage or lose the eligibility for Medicaid. The state's proposal to the federal government to do this indicated that as many as 95,000 Kentuckians would potentially lose Medicaid if this policy was put into effect. And our study suggests that people losing coverage, especially if most of them become uninsured, could have very serious effects on their ability to afford their care, to get primary care and prescription medications, to get chronic disease management and overall health effects. So I'm going to wrap up there and turn things over to Lynn, and I look forward to more discussion and comments as we go. Thanks so much for having me.
This is Lynn Quincy, and Ben, that was fantastic. I have questions of my own, but I'll defer to the audience for now. So I'll go ahead and get started. This is Lynn Quincy. I am the Director of the Healthcare Value Hub at Altarum. Altarum, oh wait, I've got to do my own slides here. Altarum is a nonprofit health services research organization that seeks to implement solutions to advance health among vulnerable populations and publicly insured populations. Inside of Altarum, the Healthcare Value Hub is a center that is supported by the Robert Wood Johnson Foundation, and we have two things that we do. We try to stay on top of the evidence with respect to interventions that might improve value for our healthcare dollar, and I'm going to explain what I mean by that. But we also are trying to create communities around the United States to work towards better value on behalf of consumers. We work with consumer advocates all around the country, as well as others who are interested in evidence-based change that makes the world a better place. So what is high-value healthcare? Well, it's a healthcare system that delivers care that is equitable, it's affordable, and it's patient-centered. But this system also uses resources wisely, and it delivers health outcomes that are uniformly high. So we're not seeing the disparities that many on the call today might be worried about. It won't surprise you to learn that right now we don't yet have a high-value healthcare system, which is why the Hub takes such a close look at the evidence to get us to such a system. Our current healthcare system, including Kentucky's healthcare system, exhibits things like high and rising healthcare prices along with unwarranted variation in those prices. There's unacceptable variation in quality, and there's too little transparency. And these are not good things for consumers. It causes a lot of consumer harm. And I'm going to focus on just a couple forms of harm with my talk today. The fact that when we have a poor healthcare system, consumers will often forego needed care due to concerns about affordability, or they might get the care, but they then have less money for housing and food. And we think of this as sort of the trio of affordability problems. First of all, there are people who might go without coverage if they can't afford the premium that would get them that coverage. We also are very familiar with data that shows that they may delay or forego care due to concerns about their out-of-pocket costs when it's time to get that care. Or the last part of this trio is maybe they got the care but they struggled to pay the resulting medical bill. And I want you to keep this trio of affordability problems in mind as I march through some new data that I'm going to share with you. Before I go into some survey data that the Healthcare Value Hub did, I do want to acknowledge our host, Foundation for Healthy Kentucky, and some important polling that they've been doing. They also looked at two of the questions I'm going to be talking about today, looking at whether cost was a barrier to getting care. In their 2015 study, they found 2 in 10 Kentucky adults experienced that problem. I believe that was non-elderly adults. And similarly, in a 2017 survey, they looked to see if adults were concerned about losing their health insurance, and they found that about 25% of adults had that concern. Well, we looked at the same questions, but even more. We conducted a poll in 2018. It was in English language only. It was a survey of Kentucky adults 18 and older, so it does include the older than 65 population. And it used a web panel, which is a different survey technique than the random digit dial that Ben was describing. However, it does yield reliable results that tell you a lot about what's going on in the state of Kentucky. And I'll share when our findings dovetail with other survey results that we've seen from other researchers. And this was a wide-ranging survey. I'm actually just going to share a few of the results with you today, and we welcome questions about some other stuff that I didn't have time to get to. So what did we learn? Well, there are two big headlines, and the first one is that adults in Kentucky, and this would be all adults, not just low-income adults and not just uninsured adults, face very high health care affordability burdens. But the survey puts some real numbers on that general finding. The shocker is that almost 3/4 of respondents, that would be 3/4 of adults in Kentucky, reported one or more health care affordability burdens. And as a reminder, those burdens include, did you, among the uninsured, what was the reason that you didn't have insurance? And 67% of the uninsured reported that the cost was the reason. Among all adults, more than half reported a cost-related barrier to getting care. And further, more than half reported that they got health care, but they struggled to pay the resulting bill. And so 3/4 of adults reported one or more of the problems that you see on the screen here. We've got further detail about what's going on, drilling down into whether or not they experienced a cost-related barrier to getting care. The most common barrier that was reported is that they delayed going to the doctor or having a procedure done, 40% of respondents. But in very high numbers, they also reported avoided going to the doctor altogether or having the procedure done. They skipped altogether the recommended medical test or treatment. 30% did not fill a prescription, and others cut pills in half or skipped doses of medicine or had problems getting mental health care. So what we're doing is taking some common questions that you might see in other surveys, but really drilling down to find out how did you experience your affordability burden. We also asked, how does affordability-related concerns compare to other reasons that you might not have gotten medical care? We gave respondents or the survey takers a total of 14 different reasons that maybe they delayed getting care, with cost being just one of them. But cost was the most frequently cited reason for delaying care. 27% cited that reason, whereas among all the 13 other options, the most commonly reported options for delaying care was taking care of it myself, home remedies, could not get an appointment, could not get off of work, not covered by insurance, or too nervous or afraid. So there were other reasons, but cost, again, was the most commonly cited reason. You'll remember that another part of our trio of affordability problems is that you got the care, but then you struggled to pay your health bill, the resulting bill. And more than half of Kentucky adults reported this type of problem. It manifested itself most commonly with being contacted by a collection agency, and fully 1/4 of Kentucky adults reported they had been contacted by a collection agency. In descending order, 20% reported they used up all or most of their savings. They were placed on a long-term payment plan. They struggled to pay for other basic necessities like food, heat, or housing because they were paying that medical bill, or they racked up large amounts of credit card debt, or they had to borrow money or get a loan. So lots and lots of struggles out there. Here's just one story that appeared on Vox in January of this year to illustrate how this unfolds for consumers. Brittany Cloyd went to the emergency room after a night of fever and increasing pain on her right side. After tests, it was determined that she had ovarian cysts. It was not appendicitis, even though it may have seemed like it to her at the time. And the insurer denied coverage. This has been in the news for other reasons, citing the emergency room visit as inappropriate. And that left this family with an almost $13,000 ER bill that I think folks on the call today will recognize that would be a struggle for most families to pay a bill of that size. So that's how it happens for consumers. I want to move on to a few more findings. Not everyone is currently experiencing a healthcare affordability problem, but they are very worried that that's going to happen to them in the future. Respondents in our survey reported very high levels of worry. Among the highest numbers that we saw were worries that they would be unable to afford medical costs when they were elderly. That was almost 3/4 of respondents. Worries that they would be unable to afford the cost of a serious illness or accident, and worries about prescription drug costs. They also had a lot of worries about health insurance, and they took two forms. The blue bars on your screen show how often people were worried that their health insurance would become too expensive. And you'll see that unless you have military coverage, so that would be TRICARE, veterans, etc., you have pretty high levels of worry that you're going to be priced out of your ability to have your current form of health care coverage. But folks also had a worry that they would lose their health insurance. And you can see that this is where we see a really big difference by type of coverage, with people on Medicaid now having extremely high levels of worry that they're going to lose that coverage. And we thought that was a surprising finding, perhaps very evocative of the times. We collected, since we had almost 1,000 respondents, we were able to do some work on how this varies by region. We did a report by each of the regions on your screen right now, 5 of them. Short report because we can't drill down quite as far, and I'm just going to share how they compare based on one measure. This is the first measure that I showed you, the percent of Kentucky adults with any type of affordability burden in the past year. This would be a healthcare affordability burden. And you can see that responses range from 80% of adults in eastern Kentucky have some type of healthcare affordability burden to a low of the Louisville metro area where it's only 64%. And those who are familiar with the landscape of the regional differences in Kentucky, I'm sure these results will not surprise you. More detail by region is available on our website. I want to move on with the time I have left to our last big headline finding. We we had respondents tell us what their political affiliation was, and we looked at how the survey responses differed by that political affiliation, and we found some surprising results. In a nutshell, we found general agreement on a whole host of questions regardless of people's political affiliation, and this is very encouraging. Regardless of your political affiliation, folks did not agree with this statement, we have the greatest healthcare system in the world, ranging from 16% to 25% who did agree. And there was a lot of agreement, about 3/4 of all respondents, that the healthcare system needs to change. There was major agreement about what are the drivers of high healthcare costs. And you can see that these rows generally do not vary very much depending on your political affiliation. And then finally, there was very high and unanimous agreement about changes that need to happen. We asked for people's opinion on a whole host of changes, and almost all of them people thought would be they agreed or strongly agreed with the change, generally over 90, regardless of the change. These were our highest votes getters, although again, not really a meaningful difference. Things like make it easy to switch insurers if the health plan drops your doctor, show what a fair price would be for specific procedures, require insurers to provide upfront cost estimate to consumers, authorize the Attorney General to prevent price gouging, etc. Here's a few other strategies that we solicited their input on, and these all garnered 90% or more of support. When we first presented these findings back in May, when we released the data, the people in the room coined a new hashtag called #PoundWeAgree, because they thought it really gave us a basis for working on healthcare affordability problems in Kentucky. So what's the bottom line? I have 3 takeaways for you. One, there are very high levels of burden in Kentucky and very high levels of worry, and this is a concern that really must be addressed by policymakers and other stakeholders in the state. Second, there are high levels of support for change. This is across party lines, and that really gives the state a basis, I think, for moving forward. And this shouldn't surprise us. When people experience a healthcare affordability burden, it doesn't care what your political affiliation is. It has to do with what is your health, what kind of coverage do you have, and what kind of, what is your income. But then finally, maybe less obvious, we need to do surveys like this one that ask the detailed questions so that we have both a vivid but also an actionable picture of how Kentuckians are faring. That's what really allows us to move forward with what might need to change. And just to tie this back to some of what you heard from Ben and his wonderful presentation, coverage, in fact, I'm actually going to go to the next slide because it makes that point even better. We know both from Ben's study and many other studies that coverage is a top factor to improving access to health care, to improving the coordination of care across providers, and getting to quality outcomes. We also know that if we are smart about our healthcare system, if it's that efficient system that Ben noted, that it's going to be easier to sustain coverage gains because we're spending our resources more wisely. What may be a little bit less evident is when we think about the different reforms that are designed to get to better healthcare value, and these are things like provider payment reform and a whole host of things, all of those interventions rely on a population with coverage. So for these 3 reasons, when we think about healthcare in Kentucky, we should think about coverage and what kind of healthcare value we're getting out of the system all at the same time. They're completely intertwined concepts. So with that, I'm going to tell you about a few resources, and I welcome your questions. The survey findings, along with lots of other material, are all available on our website, healthcarevaluehub.org. Just click on publications and you'll find it all. And we invite you to get on our mailing list. And one of the things you can do if you're on our mailing list is get updates when we add stories to our Kentucky news page. So you can get Kentucky-specific updates if you wish for those. And you do that by going to Healthcare Value Hub and our Stay Connected page. And with that, we would love to hear your questions. And Rochelle, I'll turn it back over to you to moderate.
Thanks so much, Lynn and Ben. Excellent presentation. The first question is for Ben. Ben, with Kentucky changes on the line, so if the Medicare changes happen and those 95,000 lose coverage, or if some sort of short-term health plans come down the line, what would your research suggest that we should be watching for as some of the early changes or early consequences of that? Do you have any idea? This sort of a thought experiment for you this afternoon.
Yeah. Well, the short-term plans, and I see the question from one of the participants, really affect a different population than the Medicaid changes, because the short-term plans are really being marketed to people who currently are buying coverage through the marketplace and have incomes that are too high for Medicaid. What we might see with the introduction of these new short-term plans, and for those who don't know the details on this, the Trump administration recently introduced regulations that would significantly relax the consumer protections for coverage if you purchase them through a short-term plan. But they defined a short-term plan as up to 364 days. So in effect, you can get this coverage and this will be your coverage for the year. The main changes that are apply to these plans, or the main differences in the regulations for these plans versus the ACA marketplace plans, are that you can be charged different prices based on health status. There's no guarantee that coverage for pre-existing conditions is included. The essential health benefits, or the so-called essential health benefits of the ACA plans, things like maternity care, mental health, physical therapy, rehab, those sorts of benefits that are guaranteed to be covered under marketplace plans do not have to be covered under these short-term or association plans. So when you put those factors together, the main concerns are really twofold. First is that people who sign up for these plans, while they may get a cheaper price to do it, if they actually get sick or they need services, they may find themselves surprised and disappointed at how much they have to spend out of pocket, or how little of the services they want are covered. So, all of what Lynn just talked about of the kinds of affordability issues that can arise before you use the care or after could become much worse for people in some of these plans. Now, of course, some people who generally stay in good health may benefit because they'll get a cheaper plan and they don't really use it much. But that leaves at risk a lot of the people who are potentially in need of more support for their health care needs. And then the other concern is not just the people who sign up for the plans later finding out that it's not very generous. If these plans pull away a sizable number of healthy people from the marketplace plans, what's going to happen is the marketplace plans become much more expensive. The insurers, if they only have sick people signing up for those plans, have to raise prices. And so people who have more serious health issues or people who really want more comprehensive insurance may find themselves priced out of that market. So that's the real concern with the short-term plans. The Medicaid side is very different. On the Medicaid side, the waiver program is about taking people who are currently Medicaid and requiring them to work and pay premiums. The risk there is that if people can't meet those requirements, that they just end up completely uninsured. And our work, I think, is much more directly relevant to anticipating that if people who are in this income range, people earning less than $16,000 a year as a single person or less than $32,000 as a family of four, if they don't get Medicaid, very few of them will be able to afford any health insurance. And what you're going to see then is a big increase in the barriers that people face to getting outpatient care, to getting prescriptions filled, to getting chronic disease management and preventive care. So our findings, I think, are really, really an important note of caution that if people who are low income lose Medicaid and become uninsured, there are likely to be serious consequences.
Rochelle, it's Lynn, and would it be all right if I jumped in real quick?
Of course.
I agree with everything Ben just said, but I did want to point out that we can say with a lot of certainty what would happen with short-term plans because it's basically what health insurance was like before we got the consumer protections in the Affordable Care Act. And what we know from that time period and from the work that's been done since is consumers really struggle to understand health insurance. It's a really complex product. And in order to make a decision, they will often shop based on premium because that's a concept that they know. And so it's very likely that they would enroll in these short-term products, which navigators are required to present to them because they have the lowest premium. And that they will be then surprised because even if you're healthy now, of course, the whole point of health insurance is if an unexpected medical event happens that you can't afford, that's why you have health insurance. And then it would unfold as Ben said. So I guess I just wanted to make the point that it is extremely likely that people will enroll in these products not realizing that they don't have comprehensive coverage.
Great, thanks. An excellent question from another participant, and Ben and Lynn, if you would both take a few moments to answer this. The question is, when you share this information, the research that you shared with us today, with policymakers, how do they respond? And if you have any examples you want to share with us or insights, I welcome that. Ben, if you want to start.
Yeah, I mean, it won't surprise anybody to know that the response in part depends on your political affiliation and your political views of the Affordable Care Act. So, for instance, I had the opportunity to present this work in a couple of settings where Governor Beshear was present, who presided over the Medicaid expansion, and he thought the findings were really important and cited in his book, and has been very eager to get these results out there. But I think critics of the Medicaid expansion, it takes a different set of factors into account to really kind of discuss whether it's the right thing to do, whether you should expand Medicaid. And if all you worried about was the impact on beneficiaries, on low-income adults, I think our evidence is really strong that expanding Medicaid is going to help people. But I think thoughtful critics of Medicaid expansion say, well, are there any downsides? And in particular, what are some of the cost implications? And that's the conversation I think is reasonable to have about how do we spend our societal resources. I'll say that some of the work we've done has shown that the health benefits, and in particular some of the mortality benefits in our earlier work, were quite cost effective compared to other programs that we spend money on. And I think that that's been a helpful point to make talking to policymakers. And the other factor, of course, is that the Medicaid expansion, or the ACA, at least from the state perspective, is very generously funded by the federal government. And there have been some studies that we've done and others have done that show that in states like Kentucky that the impact has been not either essentially neutral, or in some cases even beneficial to the state budget because of offsetting spending on other types of health care and the additional revenue being brought in. But in some cases, in some states, that's not always the case, and there are some states that will have to spend real resources that you might have to divert from elsewhere, and they have to decide if that's a worthwhile investment. The one perspective and response I hear from policymakers that I don't have a lot of patience with is when people continue to argue that health insurance doesn't matter, or that Medicaid is bad or being worse than uninsured, when ours and many other studies have shown that's not the case. It makes a real difference to people's lives. You can argue about how much it's worth spending and the best way to deliver that coverage and deliver care, but I think it's dishonest to argue that having health insurance doesn't matter to people's lives, and our evidence is pretty strong on that.
Thanks. Lynn, did you want to weigh in on this question about sharing your results or sharing information with policymakers?
Yes, although I don't have very much to say. So I'm not, for those of you who don't know me, I'm not based in Kentucky, and so I've been working with local advocates as to what to do with the results. So I think in a way there's still a process of presenting the results to policymakers and suggesting what some reasonable next steps might be. One next step that I'll mention, because it's related to Angela's question in the chat, is coming up with a way to define affordability for the state that could be used as a metric going forward, so there was a consistent way to talk in the state about healthcare affordability. You folks on the phone may know that there's not harmonization across programs. Medicaid, CHIP, the Affordable Care Act, and other, the IRS, all have different standards for what they think is reasonable for a given family at a given income level to contribute to health care. And to harmonize that for state purposes and have a conversation about health care affordability in a way that we're all talking the same language is one possible very useful step going forward.
Thanks, Lynn. Thanks, Ben. Any concluding remarks from Ben or Lynn that you want to share with our audience, our mostly Kentucky-based audience on the call today? I welcome your final thoughts. And before you all chime in with your final thoughts, I'll just go ahead with my last-minute things. Friends on the call, I will send out a post-event survey. I welcome your thoughts on our webinar today, and I would love to hear what you thought about it and your suggestions for future webinars. Reminder to everyone on the call that I'll post the slide deck later today to the Foundation's website, healthy-ky.org. And I'm always here to answer questions or support the work of health advocates across Kentucky, so I welcome your email or call. Ben, did you want to give a few concluding remarks in our final moments of the webinar today?
Yeah, I mean, I think that the last question before about how do policymakers respond, I think it raises the really important question of, well, what's the role of evidence and data in policy? And I'm not so naive to think that it's the primary factor, but I do think it is one factor, and the more evidence, the more that we can kind of get information out there, that it becomes a part of the conversation, and that can be really valuable. And I think some of the best policy outreach that's done is at the state and local level. I do talk to federal policymakers. I spent some time in Washington, D.C. I do sometimes talk to state and local folks. The people that policymakers most want to hear from are their constituents and their local stakeholders. And so all the people on this call, you're in the best position to kind of bring this sort of evidence and information into the debate in Kentucky. And I hope that it's useful to you. And I'm always happy to talk more. If you want to reach out to me via email, please do, and I'd be happy to follow up and try to help out how I can, because our goal really is that policymakers have good and accurate evidence when they're making these decisions that affect people's lives.
I love following Ben because I can just say what he said. I echo what he said, and I just want to thank the Foundation for having us today. It was great to be able to share this information with you.
And I'll echo Lynn. Thank you so much for having us. This really was great. I really enjoyed it.
That concludes our call today. This is Rochelle. I'm here at the Foundation for a Healthy Kentucky. I'm honored to support the work that the health advocates do across our state to improve health of Kentuckians. My sincerest thanks for Ben Summers and Lynn Quincy for being on our call today and sharing their research with us, and also having a great discussion on how we can communicate this evidence to policymakers and others so that all of us can understand the outcomes of the Affordable Care Act and Medicaid expansion in Kentucky. Thanks to each of you. Please do take a few moments this afternoon to take the post-event survey that I'll send you via email. My sincerest thanks again to Ben and Lynn. I hope each of you have a great afternoon. Thanks for being on our call today.
Bye-bye.